Okay, treatment for metacarpal fractures. If they're going to be if they're a displaced fracture, the doctors will usually choose to do pinning or plates and screws, just to make sure that it doesn't continue to displace in the future. There's so much force that can be placed to those metacarpals with the long finger flexors and extensors that we need to make sure that we're not just continue to redisplace things over and over again. So they'll do some internal or external fixation with percutaneous pins. That's what this is here. This is a pin that comes out through the skin and it travels through that metacarpal there. A lot of times we have to splint around that, so we have to like put some padding around it, create a bubble around it, and then splint to protect that pin there. We talked about boxer's fracture, specifically just the fifth metacarpal there. The sequence of therapy is going to revolve around the general sequence is going to be active and active assistive range of motion, just to keep edema down and get some light mobility of the fingers, possibly the wrist when it's cleared. Then we're going to follow that with passive range of motion. That's where we begin to kind of work through some of that capsular tightness, any of the any of the tendinous tightness that happens with muscular tendinous juncture stuff, and then joint mobilizations. I'm going to hold off on joint mobilizations until I know that fracture is well healed. So I need clearance from a doctor that says that X-ray shows that you are well healed and cleared, and then I'll begin joint mobilizations, not earlier than that. And then we'll begin gentle strengthening and weight bearing as tolerated. I may do some static progressive splinting where I fabricate a splint that's going to pull them into a tight stretched position, probably about a 5 out of 10 on the tension scale or discomfort scale. And then as we progress and we get further and further along, we'll just keep inching that down on the orthosis. Kind of depends on what the patient's tolerance is. So that's the general procedure for that. Phalangeal fractures or fractures to a phalanx. Bunches of the bones are phalanges, so it's one of the more common fracture sites in the hand, if nothing based on probability. If there's so many more bones in the hand that are phalanges, so they can be divided into a couple of different types: a base fracture, a shaft fracture, or a head and neck fracture. That's kind of self-explanatory. And even small fractures can have a significant impact on mobility. This is just a very tiny little fracture on the volar lip of that first phalanx. So you've got metacarpal here, first phalanx here. That little tiny fracture can cause all kinds of problems. Not only can it disrupt the volar plate, it can cause complications with the articular surface here. And if you lose articular surface coverage there, you may lose joint stability. And so that joint may be more prone to dislocate dorsally. And so we end up with all kinds of problems, even from the smallest fracture of the phalanx. If nothing else, the edema can have big significant issues with making stiffness. And I've had patients who just had a little tiny pinky fracture and they lose all function, have significant pain, and causes all kinds of life complications because of what seems like I just broke my finger, but those become a really big deal if not taken care of. So think of the finger as one whole unit, and oftentimes the hand as one whole unit. So patients will say, I just had this little fracture on this little part here. Why is the whole finger swollen? Why is the whole hand swollen? The body can't send edema to an isolated phalanx, nor can it send it to an isolated digit. It's going to send it to the whole container. So that whole container of a hand is going to swell up. It's going to have issues with coloration. It's going to have issues with bruising. You're going to have stiffness in neighboring fingers that weren't even affected by the fracture just because of that edema and lack of motion. If the middle finger is not moving well, then we know the ring finger and index are probably not having normal joint travel and tendon excursion as well. So all of that stuff affects neighboring digits, the whole hand. So patients are sometimes not sure why, hey, how come I have all these issues with everything else when it was only one digit? Well, it's all one container, so it all has effect there. TUFTS fractures, it's basically just a little like comminuted fracture at the tip of that third phalanx. Oftentimes sports related, but a crush injury. It can either be like a jamming force that fractures the tip of the finger rather than jamming the PIP or MCP joints, or it can be crushed like a top to bottom crush injury. There's not a ton that we do with these. It can cause some injuries. You can see kind of the ghost image of the nail bed here. It can cause some injuries to that nail bed that will affect nail growth in the future. Just hard to say about that until you wait a couple of months and know how that nail is going to recover. Mostly the treatment that we do for this, because there's no articular surface out there, if there's no major soft tissue damage and there's no rupture of the insertions of the flexor or extensor tendons, basically you just you protect it during the healing, and mobilize any areas where that are yet unstable. You immobilize those, and you work to mobilize stiffness. So if this little TUFTS fracture causes swelling in the entire digit or the distal end of the digit, you may have to work to get that DIP joint mobile again. But if anything's unstable, like if it happens to creep down a little bit, you may need to immobilize that, but mostly just splinting to protect it. And then once they're clear, you start mobilizing as ready. So nothing too complicated there. We talked a moment ago about a volar lip fracture. That's a really common fracture to the volar aspect of a PIP or DIP joint. And that little fracture can, like we said, affect the volar plate. It can cause scarring or adhesions to that volar plate. It's a relatively delicate ligamentous structure, that volar plate is, and it protects the finger at the at each of the articulation points. It keeps it from hyperextending, and so what happens is that when that gets scarred in, it shortens and creates a flexion contracture and can lead to long-term stiffness. So those volar plate fractures seem like little teeny tiny things, but that little fragment can cause all kinds of havoc within that volar plate structure. You want to mobilize early as long as it's stable, and keep it moving a lot. It's lots of home program stuff. It's lots of joint mobility when that fracture is stable. And it's really common not to get full and complete range of motion back. It's very common to see patients who have that long-term stiffness from that small little volar plate fracture. So that's often pretty common. Jersey finger, another common sports-related injury. It is a zone 1 bony avulsion of the flexor digitorum profundus. As that bony piece ruptures off, you may have a jersey finger where it's a rupture or laceration of that flexor tendon that doesn't involve a bony avulsion. Most often, it's that a little piece of that bone popping off of there. So, if that happens, you'll notice that the patient in the field is unable to flex the DIP. So, a mallet finger is where it droops and they can't extend it. That's an extensor tendon rupture. This is a flexor tendon rupture, and it's a little avulsion there or a little laceration of that flexor tendon if they actually have like a cut from carrying something that cut them sharp. But that they lose the ability to flex the tip of the finger. So if you have them make a fist and all those other fingertips tuck under, that one is sticking out and it can't tuck under. In order to treat this, you think, oh, it's just a simple little fingertip. We're going to do a little splint. Nope, you are in a full flexor tendon protocol for 6 weeks. You got to do a full-on flexor tendon protocol because it's a long flexor tendon, and if we don't work to immobilize that, the whole thing could shrink up and retract into the forearm. Remember, it's a common muscle belly, so it won't that one won't shrink all the way. The others kind of keep it from doing that, but you're going to end up with some major long-term problems. You're going to lose flexion of that finger, and you may end up with other problems flexing the PIP if stiffness sets in. So full flexor tendon protocol for that. PIP dislocations. So when we look at volar versus dorsal dislocations, they have significant differences and implications of what structures are damaged. So think when it's a dorsal, if we're talking about this is the PIP, proximal interphalangeal joint. If you think about where the second phalanx goes, that defines whether it's dorsal or volar. So if I have a dorsal dislocation, the second phalanx went dorsally. If I have volar dislocations, because the second phalanx went dorsally. The structures damaged, however, are affected by the first phalanx. So if that second phalanx goes dorsally, the distal head of the first phalanx is now pressing on the volar plate. So it's going to cause a volar plate injury. If the second phalanx goes volarly, that distal head of the first phalanx is now pushing on the extensor tendons. So you're going to have an extensor tendon problem. So as long as you can figure out how to label them, wherever the P2 goes, that's how you label it, volar versus dorsal. And the damage is done by the distal head of the first phalanx, okay? So it's poking into extensor tendons, or if it's poking into the flexor tendons or volar plate, okay? So that's what this says, basically what the volar and dorsal versions will affect. Super important, if you see a patient who's got a little dislocated finger, do not reset that in the field. You can cause ruptures to other structures if done incorrectly. I can almost guarantee when they get to the ER, you're going to find an ER doc that's going to say, oh, I got this, and they're going to pull and reset, and they may very well do the same thing. I would not send someone with a PIP dislocation to an urgent care because they're going to do it there and maybe not know what they're doing. So if I have a friend or if I had a PIP dislocation, I'd go to the ER and say, I want to see the hand surgeon on call, and he's going to reset this. I'm willing to pay that extra money to make sure we don't rupture a flexor tendon or extensor tendon in the process. If it is a dorsal dislocation, we're going to do a custom splint into flexion. So that's this one, right? P2 went dorsal. We've damaged the volar plate. In order to protect the volar plate after this has been set, they're coming to me after it's been relocated. After they come to me, they're going to be put in a dorsal blocking splint that's going to keep that PIP in 30 degrees of flexion, and then they're free to bend down into more. So we allow them to flex more, but we don't let them to extend past that minus 30 degrees. That keeps the volar plate from being overstretched and re-ruptured. If it's a volar dislocation and we've damaged the extensor tendons, because the distal head pushed on that extensor tendons, I'm going to splint them in extension. If I put them in an extension splint, that allows that extensor tendon to repair without being stressed and loaded. Okay? Therapy is all about protected mobility, getting them to move within protected tolerance. Okay? So I'm allowing them in this one to flex, because that allows the volar plate to shrink down, but I'm not stretching it and putting tension on it past that minus 30 degrees. Okay? CRPS. Let's talk a little bit about chronic regional pain syndrome. There's two types. We used to call all of it RSD, but now they've kind of renamed things. RSD, reflex sympathetic dystrophy, is what it stands for. That is no direct injury to the nerve, but it's pain triggered by other noxious, painful events. So a lot of times it's this sympathetic nervous system gone haywire, right? It's the sympathetic or parasympathetic nervous system perceiving something that is not actually that much of an assault to the system, but just kind of ramping up out of control. Causalgia is a direct, partial, or full injury to a nerve or major branch. So that's when you actually have a damage to part of the brachial plexus, typically a sensory nerve component, but you have some actual damage to the nerve. Okay, there's a cause to it. It's causalgia. RSD is this sympathetic nervous system dysfunction. Symptoms: significant pain, edema, typically brawny. Brawny edema is this thick, immobile edema. The earlier stages has less of that. It progresses as they get further along. Stiffness to the affected area, and a stiffness that is pervasive and stubborn and intense stiffness. And trophic changes: skin temperature. You'll have changes in the color of the skin. You'll have changes where it becomes shiny, and you'll have hair growth they've never had before. Sometimes very dark black hair growth in new areas that had no hair at all before that. So that's kind of an unfortunate thing. Pain. There's three types of pain dysfunction common with chronic regional pain syndrome. Allodynia is non-noxious stimuli results in a pain perception. So you just brush them or touch them, or their jacket brushing up against that hand, that causes pain. It shouldn't. That's allodynia. Hyperalgesia is noxious stimulus, have excessive pain perception. So if they were to poke themselves with a needle, that's going to hurt. No big deal. I move on. That's something that causes them excessive pain. Okay. Hyperalgesia is an over intense pain response. Hyperpathia is excessive pain perception, perseverates for abnormally long periods. So it's just about how long that pain hangs out for. Okay. Those three different types of pain dysfunction are really common within CRPS. Stages. Both of the types will have very common presentation. So for all intents and purposes, it's just easiest to understand the stages as they exist as the same, even though there's different etiology that leads to each cause, or each type rather. So an acute inflammatory phase, that's 10 days to 3 months. Big old giant block of time, 10 days. For example, it often happens with a distal radius fracture. So a patient is like a week out from the distal radius fracture. They go back to the doctor. Doctor says, yeah, you should probably go to therapy, start to work on it. Within a couple of days, if they're not getting into therapy, the patient that walks in holding their hand up in front of their face and being super careful and like, oh, don't touch it, don't move it. They're too cautious about it. It's super sensitive. They're not moving, so it's stiff. These are the patients we have to worry about. Sometimes you get them at the 3 to 4 week mark because, oh, it hurts so much. I wasn't ready for therapy yet. Those things add up and cause problems. It can be reversed relatively easily if caught early. You catch them in that early stage, you can reverse that train and change it all. If you don't, it's way harder to catch or way harder to reverse. Symptoms often include a flushed, warm, or dry hand. Pain is diffuse but severe, so they can't pinpoint where it hurts. It's just that whole arm-hand complex hurts. They'll have that early edema. It won't be brawny yet, but they'll have this edema that almost makes the fingers look pointed, and they may start to develop that hair growth if we're getting close to that 3-month range. Okay. At the end of the stage, the limb becomes cold, sweaty, and brawny. So it's not like at the 3-month mark spot on, but as you start to get that end of that 3rd month, the whole limb starts to take on a different presentation. Okay, instead of being warm and red with flushed with blood, it becomes cold and sweaty, almost a little pale, and that edema starts to get very solid and kind of coagulates in there. Dystrophic phase, 3 to 6 months. Symptoms include constricted blood vessels, partly from edema, partly from the sympathetic nervous system response. Blood vessels all constrict. A waxy appearance that has to do a little bit with the shininess, but it definitely looks like not typical skin. Pain turns into more of a burning and throbbing. You get grooved nails. You can end up with these longitudinal grooves in the nail, just because the protein response from the sympathetic nervous system is having a change in how the nail bed produces those nail cells. Muscle wasting and joint stiffness worsen, and you get significant black hair growth that becomes much more prominent in that 3 to 6 month range. And atrophic. If you enter this stage, you've got a patient who has significant problems, and it is unlikely that therapy is going to get them out of it. They may need other interventions, nerve blocks, that kind of thing, but this is a patient whose hand is going to be non-functional for the foreseeable future, if not for forever. It's really tough to reverse the atrophic phase. 6 months and over. Symptoms include irreversible damage to muscles and joints. Those joints have just been so stiff for so long. It is so hard to get those joints loose again. I've seen patients undergo capsulotomies and tenolysis, and it just ramps up their pain, and they just don't get the outcomes that are to make it worth the surgery. Bones begin to lose density and weaken. Ankylosing of the joints. Pain lessens. They actually have less pain in this stage because the nerves are just starting to kind of die off a little bit. And then skin cools further and begins to look a bit cyanotic, and it just becomes a very abnormal looking hand. And the limb becomes non-functional due to loss of use and pain. These become patients whose hands are kind of chronically up in front of them, or they're down by their side, not using them. It's not even a helper hand for someone who's just stiff, but they can kind of learn to function with it. Almost like a cosmetic prosthetic. Now, these patients don't even use it. They want to dissociate from it entirely. And we can talk about this more in the lab section, but the CRPS patients, like I said, if you catch them early, it makes a huge difference. But when they get to this stage, it's hard to reverse. So when I see a patient walk in the clinic and they're holding that hand up in front of them and they're talking about how the pain is just everywhere and it's all over and they have massive edema, I go into kind of a whole different mode of treatment. We start doing things like graded motor imagery. We start doing desensitization stuff. We start doing massive amounts of edema control. I had a patient come in just the other day talking about their hand. It was a female, and she was referring to her hand as he this and he that. And I stopped and said, we have to reorient this hand to you. It is part of you. It is not this third person object out there that's just a different entity. We have to start to have a conversation about your hand this and my hand this. And I went to the store and he was hurting the whole time. No, I went to the store and my hand hurt the whole time. We need to keep this connection to this mind-body link, or it gets very hard to get them out of that cycle, and it just starts to perseverate and they dissociate from it even further. So CRPS treatment, it is a true team approach. It is something that if you're out there as a therapist and you're completely on your own and you're plugging away at this and the physician is completely oblivious and they say, wow, why are you so stiff? What's going on? It's hard to overcome that. So you really need to work with pain management. The physician and therapies, OT, PT, everyone involved needs to be on the same page. It's as much psychology as it is therapy, physical or occupational therapy. Nerve blocks are an option with physicians. That's typically more successful if it's causalgia. RSD has a little bit less success with that, but you don't know until you've done 1, 2, maybe even 3 nerve blocks is when you're likely to see the best results. So 1 is not necessarily a good test of whether or not it's going to work, but that's got to be led by the pain management or original hand surgeon if that's going to be something that's initiated. Graded motor imagery. I'm not sure how much you guys have talked about this, how much it's pertinent in your practice, in what you guys are learning about practice, but it helps to change the sympathetic nervous system's perception and response to pain. And it's a way to kind of trick the brain into thinking, oh, we're moving without pain, and we're getting a better concept of how this body part is supposed to move and integrate with the rest of my body. 3 steps to it. We won't go into a ton here. We can answer more questions in the lab if you guys have questions. There's laterality, identifying an awareness by sight about right versus left. That reintegrates the concept of the injured side, whichever it is, back into normalcy. Then we go to motor imagery, and we'll actually sit with the patient and say, I want you to picture writing your name with your right hand, assuming the right's affected. I want you to visualize that. Don't actually do it. Sit here, do it. Visualize, and it starts to make the brain realize this hand can move without pain. There's a very powerful research behind this too. That it seems a little abstract and a little maybe new age, but it's highly effective. And then mirror box therapy. We can talk about what that looks like and how we can trick the brain into again thinking that that side is moving pain free, and it kind of turns the dial of intensity of pain down and can break that cycle that they get stuck in. And then we do not do, oh, I'm sorry, back up. Weight bearing and proprioceptive input is highly effective with these patients. If you can get them doing any weight bearing, there's something called a Distal that's an old school tool that is this box that you just basically, their hand fits on really well. Little, I don't know, like the size of half of a shoebox, and they put their hand on top of this plastic thing, and when they push, they get a little auditory cue, and a little light pops on, they come off, it turns off. So you're getting this biofeedback kind of thing with weight bearing, proprioceptive weight bearing through that hand. So load bearing through things, and just giving lots of input to those joints also helps to kind of reset the sympathetic nervous system. So that can be really effective as well. Most important, we do not do aggressive passive range of motion. This will spike pain and further this downward spiral. The tendency is there, the temptation is there. Well, they're stiff. What do we do to get past stiffness? We push harder. No, that's just going to further the cycle. These patients almost want to be pushed. They're like, my hand is stiff. I just want you to stretch it. It hurts so bad, but I want you to do it. It's not worth it. If it spikes a pain response, you're just feeding into the sympathetic nervous system loop, and it causes a problem. So we can do joint mobility. We can do light, low load, prolonged stretch, but I'm not doing it aggressive where I'm cranking and they're banging on the table. That is not effective approach for this. So, and last, here's all the references we have, just a couple of them here we looked through. So hopefully that covered everything we need. We'll answer a lot of questions in the lab. I'll go over some of the common exercises. We'll go over some of the tests, the provocative testings, and then we can even go over some of the CRPS graded motor imagery. So come with any questions you have about the stuff we covered. We'll answer that, and we'll go over some other stuff, maybe even some case studies where you guys are getting an idea of exactly what we're doing with therapy. So, all right, I think that's everything. Thanks.